Welcome back, guys. Now, in this series of rapid revisions, we have already completed general physiology. Now, in this video, we'll be discussing about nerve and muscle physiology. Okay, so now first let's begin with the muscle physiology. So, in this revision videos, I'll be covering all the important topics which are needed for your exams. Okay, before going to your exam, so if you go to this one video on muscle physiology and nerve physiology, that will be enough for solving most of your questions. Okay, having said that, now how many muscles are there? There are three types of muscles. What are they? One is skeletal muscle, next cardiac muscle, and smooth muscle. Now, first let's begin with the skeletal muscle. Important points about the skeletal muscle. See here, in the skeletal muscle, for example, if you see a muscle, inside the muscle, what do you have? Inside the muscle, there are many fascicles present. Inside the fascicles, there are myofibers present. And the muscle fibers present. I should say the muscle fibers are the myofibers present. These muscle fibers, okay, these muscle fibers which I am highlighting here, these muscle fibers, they are the real myocytes. Okay, these are the real myocytes. So inside this myofibers or muscle fibers, there are myofibrils. Okay, there are myofibrils. These myofibrils, okay, these myofibrils, they are made up of myofilaments like actin and myosin. Okay, so tell me guys, muscle, inside the muscle what do you have? Fascicles. Inside the fascicles what do you have? Muscle fibers. These muscle fibers are the real muscle cells, the myocytes. Inside these muscle fibers, okay, if I am showing you one muscle fiber, imagine there is a one muscle fiber. Inside this muscle fiber there are actin and myosin filaments present. Okay, actin and myosin together, myofibrils present. Done. Now let's start from the basics. Okay, let's start from the basics. Say in the sarcolemma. Okay, sarcolemma. In the sarcolemma, which proteins are present? The proteins present in the sarcolemma. So, in a few exams, this question has been asked: which of the following is a sarcolemmal protein? Which of the following is a peripheral protein? Which of the following is an integral protein? So, if you look at this is the muscle cell membrane. Okay, here I am showing you this is the muscle cell membrane. Now, in this muscle cell membrane, there are some proteins present. For example, this first protein which I am showing here. This first protein which I am showing like this. Okay, so this protein is called as a dystroglycan. Okay, it's called as dystroglycan. Next protein which I am showing here in the green color. Okay, this protein which I have shown you, which is consisting of different subunits. Okay, it's having different subunits. So this protein which is also present in the muscle cell membrane, this is called as sarcoglycan. Okay, so what are the first two proteins which I have discussed? Dystroglycan and sarcoglycan, and one more protein which is present here. So this protein is called as sarcospan. The important point about these three proteins are this dystroglycan, sarcoglycan and sarcospan. These are all integral proteins. All these three fellows are integral proteins. Okay, they are all integral proteins. Okay, they are present within the cell membrane. They are present within the cell membrane, so they are called as integral proteins. And there are also proteins which are present. Look here, there is also a protein which is like this. Okay, which is attached to one side of the cell membrane. Okay, which is attached to one side of the cell membrane. It is giving tensile strength to the cell membrane. So this protein, which is attached only towards one side, that too intracellularly, it is attached towards the intracellular side of the cell membrane. This protein which I have shown in the blue color, this is called as dystrophin. So tell me, dystrophin, it's a peripheral protein. It's a peripheral protein. And one more peripheral protein which I want you to show here. So there is one more peripheral protein which is called as syntrophin. Okay, this yellow color protein which I have shown, it's looking little messy, but this protein, this is called as syntrophin. So tell me, syntrophin, it is also a peripheral protein. So in total, how many proteins are there? In total, I have explained you there is a dystroglycan, sarcoglycan, sarcospan, dystrophin and syntrophin. Okay. So which of the following is a peripheral protein? Syntrophin and dystrophin are the peripheral protein. So if you have deficiency of this dystrophin, already I have explained you this in the general physiology itself. What is the problem? Okay, if you have the deficiency of this dystrophin, that's going to cause Becker's muscular dystrophy. If you have complete absence of this dystrophin, okay, if you have complete absence of this dystrophin, is going to cause a disease called as the Duchenne's muscular dystrophy. Okay, Duchenne's muscular dystrophy. So already we have seen this thing. And intracellularly, look to which component this dystrophin is attaching. So this dystrophin intracellularly, it is attached with which filaments? This is actin. Okay, this is cytoskeletal actin. This is not the actin which is involved in the muscle contraction. No, not that actin. So there is a protein, okay, called as a dystrophin. This dystrophin intracellularly, it is going to be attached with actin filaments. Okay, intracellular it is attached with this filamentous actin, F actin. This is F actin, filamentous actin. Okay, so these are the proteins in the sarcolemma. Next, after this, let's talk about what are the proteins involved. What are the different types of proteins which are present in a sarcomere? You know, in a muscle, sarcomere is a functional subunit. Okay, functional unit of a muscle contraction. What is the functional unit of a muscle? That is called as a sarcomere. Sarcomere. Okay, so sarcomere, it is present between which lines? Present between two Z lines. It's present between two Z lines, sarcomere. Sarcomere is a functional subunit of a muscle. Functional subunit of a muscle. Next important points about the sarcomere is made up of, okay, what are there in the sarcomere? What exactly are there in the sarcomere? Look carefully. In sarcomere, there are contractile proteins present. Okay, contractile proteins present. What are the examples? Actin and myosin. Okay, actin, myosin. Next, there are regulatory proteins present. What are the examples of regulatory protein? Troponin and tropomyosin. Okay, and also there are anchoring proteins present inside the sarcomere. Within a sarcomere, the one which contracts, the one which actually contracts, okay, sarcomere, within the sarcomere, there are contractile proteins. Just now I have explained you contractile proteins here, and regulatory proteins are there, and also there are anchoring proteins. Okay, anchoring proteins present. So what is the function of these anchoring proteins? They keeps the sarcomere intact. Okay, they are keeping the actin filaments, myosin filaments, their length of the filaments to be precisely monitored with the help of these anchoring proteins. They take care about everything. Okay, they are keeping these filaments, other filaments in place. Okay, so can you give us any examples of anchoring proteins, sir? Yes, there are anchoring proteins like desmin. Okay, next anchoring proteins like nebulin, titin, okay, alpha actinin, and so on. So these are the important anchoring proteins. Now look, for a better understanding, now let me show you what exactly is a sarcomere. Sarcomere, in the sarcomere there are contractile proteins, regulatory proteins and anchoring proteins. I will explain the function of these anchoring proteins and regulatory proteins, but first of all you have to know what is the structure of the sarcomere. These are the components of the sarcomere. Okay, what are there in the sarcomere? You know, contractile proteins are there, regulatory proteins are there, and anchoring proteins are there. But what is the structure of the sarcomere? Okay, you know the components. Now look at the structure of the sarcomere. Structure of sarcomere. So in this structure I will explain you the functions of this. Okay, structure of sarcomere. See, I have told you sarcomere is bounded by Z lines. In the periphery, what do you have? Z lines. Okay, within this myofibril, here I am showing you, these are the Z lines. Okay, now who is attached with these Z lines? Look here carefully. There are these filaments which are thin. So these filaments which I am showing here, these are the thin filaments which are also called as actin. Okay, actin filaments. So actin filaments are attached with the Z line. Okay, so this red color filament which I have shown here, this is a thin filament. It's called as a thin filament, also called as actin. Okay. Now tell me, actin, it is attached with what? Actin, it is attached with Z line. Actin is attached with Z line. With the help of which protein? With the help of which protein? That's the MCQ. So actin, it is attaching with the Z line, with a protein. Okay, with a protein. What is this protein? So this protein is called as alpha actinin or CAP-Z protein. Okay, alpha actinin or CAP-Z protein. So here I have explained you the anchoring proteins. So what is this? Look carefully. Okay, so in the topic of anchoring proteins, I have explained you there is something called as alpha actinin. So what is alpha actinin doing? Alpha actinin attaches the actin with the Z lines. So you should always remember the Z lines are made up of, in one of the exams this question has been asked, Z lines are made up of, or alpha actinin is a Z line protein. Okay, it's a Z line protein. So this alpha actinin, it's a Z line protein. Okay, next, so in the center of the sarcomere, you are having these thick filaments. Okay, you are having these thick filaments. So these thick filaments, which I am showing in the blue color, these are called as myosin. So myosin is a thick filament. Let me write thick filament is what? It's a myosin. Now question is, even this myosin, okay, even this myosin, it is attached with, okay, even the myosin, it is attached with the Z line, okay, with the help of this spring-like protein, So what is this? So myosin is a thick filaments, it is attached with Z line with the help of titin, So how the titin is looking like? Titin is looking like a spring, so it is called as muscle spring. That's the MCQ. So this titin, it's the largest protein in the humans. It's the largest protein in the humans. The molecular weight is also somewhere around 27,000 kilodaltons. So it's the largest protein in the humans. And next, titin, it's going to be maintaining the elasticity. Okay, titin, it maintains the elasticity. Okay, elasticity of the muscle. Okay, so what are the important points? Actin attached with the Z line with the help of alpha actinin. Myosin attached with the Z line with the help of titin. Okay, and this titin, one point which I want you to know, this titin, it is absent in smooth muscles. Okay, this titin, it is not there in the smooth muscles. Okay, next, there is one more filament. Look here carefully. Okay, there is one more filament. Look here. This filament, it is present along the length of the actin. See this filament, it is present along the length of the actin, like this. Okay, so what is the name of this filament? Okay, this is called as nebulin. Nebulin present along the length of actin. It maintains length of actin filaments. Okay guys, so in your exam there is a chance that you can get a question on nebulin, you can get a question on titin, muscle spring, you can get a question on CAP-Z protein or alpha actinin. So such kind of questions are possible. Okay, so what are the three anchoring proteins that we have completed? The three anchoring proteins. Okay, the three anchoring proteins are nebulin, titin alpha actin, these three are completed. And desmin, important point which I want you to know is desmin is an intermediate filament. It's an intermediate filament. Okay, it's an intermediate filament. It's present in the muscles. What it does is it attaches the Z line. It attaches the Z line with sarcolemma. Okay, so this protein is called as a desmin. It's a intermediate filament. Where it is present? It's present in the skeletal muscles. So this desmin, it's an intermediate filament, and you know intermediate filament are specific to the cells. They are specific to the cells. Okay, they are present only in the muscles. So that's why this desmin, it's a tumor marker of rhabdomyosarcomas. So what exactly are rhabdomyosarcoma? It's a rhabdomyo means skeletal muscles. Sarcoma means cancer. So what is the tumor marker of skeletal muscle cancer? It's a desmin. What is desmin? It's an intermediate filament. Okay, it's attaching the Z lines with the sarcolemma. Okay, so done. Now here in this sarcomere, what else I want you to know is the zones or bands. For example, say in a sarcomere, what are the boundaries? Always the boundaries are Z lines. Okay, always the boundaries are Z lines. What are these filaments which I am showing here? These are the actin filaments. In the sarcomere, in this region called as a sarcomere, there are actin filaments. These red color filaments are actin filaments, and these blue color filaments which I am showing little thicker, these are myosin. Okay, these are myosin. So now look, there is an area. Okay, there is an area. Okay, which I am showing in the dotted line. Okay, which is bounded by the dotted line from here to here. So tell me, in this sarcomere from Z to Z, so this area which I have highlighted from here to here, which filaments are present? Only actin filaments are present. The such a same area is also present here on this side. Okay, so this area, so where only actin filaments are present. So this area is called as I band. Okay, this area is called as I band. So tell me, in I band, which filaments are present? So I band, it's made up of I band for isotropic band. Isotropic band. Okay, isotropic band. In isotropic band, which filaments are present? Which filaments are present? Only actin. Okay, only actin filaments are present. So there is this area. Okay, from here till here. Let me show it with the other color. Now the area which is present between from here till here. Okay, all this area. So in this area, whole in this center area, there are actin filaments, myosin filaments, actin filaments and myosin filaments. Okay, actin, myosin filaments are there. Both are there. So this area is called as A band. Okay, A band. So A stands for anisotropic band. Anisotropic band. Okay. See, anisotropic band, it contains, tell me, it contains both actin plus myosin. Okay, it contains both actin and myosin. Now, within this A band, look carefully, within this A band, there is this one region. Okay, within this A band, there is this one region which I am highlighting with the pink color. Okay, let me highlight it with the pink color. Look, so there is this region, the center. Only which filaments are present in the center? In this central region. Look, in this central region, only which filaments are present? Only this myosin is present. Myosin is present. So within the A band, there is this central region. There is this central region which is called as H zone. So how I used to remember? H for heavy chains. Okay, H is totally different thing. It's a Heller's. Okay, that's a total different thing. But how you can remember for your exam is within this H zone. Within this H zone, what are present? Only heavy chains. The myosin heavy chains are present. Okay. Now, even within the H zone. Okay, even within the H zone, see there is a protein. Okay, there is a protein which is connecting one myosin with the other myosin. Okay. Let me show it with the purple color. For example, see there is this one protein which is connecting one myosin with the other myosin. In the center of the sarcomere, one myosin is getting connected with the other myosin here in the center. So there is this one protein. Okay. So what is this? This is called as M line. Okay, there is a line called as M line. So tell me, within a sarcomere, what is the boundary? Z line. And what is the center? M line. M for middle. Just remember M for middle. Okay, M for middle. So what else I want you to know is, see here, first point number 1, myosin in the center it is attached with, myosin it is attached with M line, myosin is attached with the M line. Okay, so with the help of a protein called as myomycin. So what is the MCQ? Myosin attached with M line. What is the name of this M line protein called as? Myomycin. Okay, myomycin. Next, what are the boundaries of the sarcomere? Okay, they will ask you to arrange in order. What is the boundaries of a sarcomere? See, always there is a Z line. After Z line there is I band. After I band there is A band. Within the A band there is H zone. So within the H zone there is M line. So order from periphery. Order from periphery. Okay. So what is there in the periphery? Z lines. Following Z lines, which band is there? I band. Okay. Next to the I band, what is there? A band. Within the A band, there is H zone. Okay. Within the A band, there is H zone. So within this H zone, there is M line. Okay. So that's it. They will ask you to arrange this in order, and that's the MCQ. Okay. Next, what else they can ask you is, say if a muscle is contracting. Okay. If a muscle is contracting, you know the sarcomere is going to get contract. Okay, the sarcomere, the Z lines comes together, so the muscle will be contracted. See, I am not going to explain the things in detail, okay, because these are the rapid revision videos. So in detail videos are available already in the YouTube, in the SARS channel. So here I am just talking about the important points. I am trying to cover as much as possible within the short period of time. So look, when a muscle is contracting, okay, during muscle contraction, what are the changes that will be seen? Which changes will be seen? Okay, which changes are going to be seen? Say, the Z lines comes closer together, comes closer together. Both the Z lines will comes close together. Next, what about the H zone? H zone remains, H and I zone, they are both going to decrease. Okay, so both this H zone and I band, okay, both their size is going to decrease. And what about the A band? Okay, this is I band, right? I band. So A band remains same. And what about the M line? M line, that line becomes more prominent. Okay, that M line becomes more prominent. So these are the changes that will be seen during muscle contraction. Okay, muscle contraction. Now I have explained you what are the components of the sarcomere, what are there in the sarcomere. You know it, there are contractile proteins, regulatory proteins, anchoring proteins. And I have shown you the structure of the sarcomere with the different A band, I band, H zone, M line, like thing. And also I have discussed about the different anchoring proteins. Okay, desmin, alpha actin, nebulin, titin. Okay. Next, what I want you to know is the sarcotubular system. Okay, within the sarcotubular system, you will understand what is the purpose of the contractile protein and what is the purpose of the regulatory proteins. Okay, so let me explain you about sarcotubular system. So what exactly is this sarcotubular system? Look here, guys. Now here is a neuron. Let's understand. Let's say something like this. Here is a neuron, alpha motor neuron. Okay, you know alpha motor neurons are the ones which are responsible for the muscle contraction. Okay, so this is the alpha motor neuron. Now look carefully here. This is a skeletal muscle. Right now I am talking about the skeletal muscle. Now say here is a skeletal muscle membrane. This is the cell membrane of the skeletal muscle. The cell membrane of the skeletal muscle is throwing these invaginations. Okay, these are the invaginations of the skeletal muscle membrane. So here is the cytoplasm. Okay, here is the cytoplasm. Now this is what? This is the muscle fiber. This is one muscle fiber. You know, within the muscle fibers, what are there? Within the muscle fibers, there are myofibrils present. Myofibrils are made up of what? Actin and myosin. So within this cell, look here, here is Z lines, here are the Z lines, many such Z lines are present. Z line, something like this. What are these filaments? Which I am showing here. What are these filaments? Actin filaments. Okay, let me draw the Z lines in black color. So here is one Z line, this is one Z line, these are the Z lines. I am talking about the one sarcomere. Okay, here is one Z, this is one Z. Now what are these filaments? These are the actin filaments. In the center, what do you have? Myosin filaments, thick filaments. Okay, so like this. Now, first let's concentrate on the sarcotubular system. What exactly is the sarcotubular system? Look, this muscle membrane, the muscle membrane is forming these invaginations, and these invaginations are called as, this invagination is called as a T-tubule. Okay, let me write here, this invagination is called as T-tubule. Okay, T-tubules. So T-tubules are present where? T-tubules are present in the skeletal muscle. Right now I am talking about the skeletal muscle. They are also present in the cardiac muscle. But these T-tubules, important, they are absent in the smooth muscles. So T-tubules are absent in smooth muscles. Okay, who else is absent? I have already discussed with you. Titin is absent. So look at this. This titin, it is absent in the smooth muscle. I have explained you. Titin is absent in the smooth muscle. This nebulin is also absent in the smooth muscle. It's absent in the smooth muscle. Okay, and one more thing, here itself I am telling you, troponin, it is present in the skeletal muscle. It's present in the skeletal muscle, but it's absent. Okay, it's absent in smooth muscle. So these are the points which I want you to know. Troponin is absent, T-tubules are absent, nebulin is absent, titin is absent. In where? In smooth muscles. All these are the MCQs. Okay. Having said that, now let's continue about the sarcotubular system. So in the skeletal muscle there is a T-tubule present. Okay. And also there is L-tubule present. Here I am showing you this L-tubule. Okay. Here is a L-tubule present. So this L-tubule, okay, let me write here L-tubule. This L-tubule is nothing but sarcoendoplasmic reticulum. Okay, sarcoendoplasmic reticulum, it's endoplasmic reticulum of the muscle. It contains what? It stores calcium. Lots and lots of calcium is there. So sarcoendoplasmic reticulum stores calcium. It stores the calcium. Okay. So now look what happens. Look what happens is, see, here there are two types of channels present. On this T-tubule, there is a channel which is called as DHPR, dihydropyridine receptor calcium channel, DHPR 1.1. Okay, DHPR, dihydropyridine receptor calcium channel. It's a L-type calcium channel. It's also called as CAV, that is voltage gated calcium channel 1.1. So tell me, where is this L-type calcium channel or DHPR channel present? The DHPR channel, it is present on the T-tubule. It's present on the T-tubule. Clear? Now one more channel which I am showing here. Look carefully. This channel, it is present on the L-tubule. Okay. This channel is called as RYR channel. RYR type 1. Okay. So this RYR type 1, where it is present? RYR type 1 is present on the L-tubule, MCQ. Okay, RYR type 1 is present on the L-tubule. So who is there within the L-tubule? Already I have explained you. Who is there within the L-tubule? Okay, let me draw it here itself. So calcium. Lots and lots of calcium is there here. So what exactly is happening during the muscle contraction? During muscle contraction, look carefully. Sir, these alpha motor neurons are going to be activated. Depolarized. Action potentials are traveling, because of which they will release the acetylcholine in the neuromuscular junction. When the acetylcholine is acting on this muscle membrane, or I should say, when the acetylcholine is acting on its receptor, okay, when acetylcholine is acting on its receptor, say this is acetylcholine. When acetylcholine acts on its receptor, now sodium influx will occur into the cell. Acetylcholine receptors are the sodium channels. Acetylcholine receptors, these are the sodium channels. When acetylcholine binds with it, receptor, when acetylcholine binds with it, nicotinic M receptor, sodium will come into the cell. As the sodium is coming into the cell membrane is getting depolarized. Now look carefully. These are the depolarizations. Okay, these action potentials, they are traveling on the muscle membrane. Okay, the action potentials are traveling on the muscle membrane. Now, because of this, which channel will be activated? Because of this, the DHPR channel will be activated. Okay, DHPR channel is activated. Now, this activated DHPR channel, okay, now this activated DHPR channel, it will comes and opens the RYR channel mechanically. The DHPR channel comes and opens the RYR channel. So, because of which the calcium from the cell is going to come out. So now for the first time, calcium from the cell is calcium from the sarcoendoplasmic reticulum is going to come out, and this calcium will help in contraction. Okay, this calcium is going to help in contraction. So now the whole event is called as electromechanical coupling. Because of the electrical event, look here, because of this electrical event, what is happening? There is mechanical opening of the RYR channel. The RYR channel is mechanically opened with the help of DHPR. So DHPR opens the RYR channel, leading to the release of calcium. Okay, so this calcium is going to helpful for us in contraction. So this is called as electromechanical coupling. Okay, this is called as electromechanical coupling. Now, once the contraction is completed, tell me, do you require calcium? Once the contraction is completed, muscle contraction is completed, do you require any calcium? No. The calcium have to go back. The calcium which was there in the cytoplasm, it should go back and it should get sequestered back. It should get sequestered back in the sarcoplasmic reticulum, again with the help of a channel. There is a channel. Okay, again there is a protein which is helping in taking the calcium back, into the sarcoendoplasmic reticulum. This channel is called as SERCA. Okay, this channel is called as sarcoendoplasmic reticulum calcium ATPase, which is an example of primary active transport. Okay, so the SERCA pump, okay, it's SERCA pump, actually it's a pump, it's using energy, right? So it is going to take the calcium back into the sarcoendoplasmic reticulum. Now, within the sarcoendoplasmic reticulum, okay, within the sarcoendoplasmic reticulum, this calcium should not be in the free form. The calcium should not be in the free form. It should not be in the free form. It should be bind. Okay, it should be totally bind with a protein. The calcium will be bind with a protein. So, what is the calcium binding protein? Okay, the calcium binding protein, okay, let me write here itself if possible. So, the calcium within the sarcoendoplasmic reticulum, it is totally bound. It is bound with calsequestrin. Okay, so this calsequestrin, it is present in every cell, skeletal muscle, myocardium, as well as the smooth muscle cells. So, calsequestrin, it binds with calcium. Okay, it binds with calcium. Okay, so now what are the MCQs which I want you to know? So SERCA is an example of primary active transport. Okay, SERCA, where is it present? It is present on the L tubule. It is sequestering the calcium back. Okay, where are RYR channels present? RYR type 1, it is present on the L tubule. Where are DHPR channels present? DHPR channels present on the T tubule. Now, one of the MCQ which I want you to know is, if this RYR channel is doing overaction, if it is working more, okay, if it's working more, if it is open for a long amount of time, so that's going to cause more release of calcium, more muscles will be contracted. So, there is a condition where there is gain of function mutation. Okay, so let me erase and write gain of function mutation of RYR channels. Gain of function mutation of RYR channels, more calcium will be released, more sustained contraction is going to be seen. That condition is called as malignant hyperthermia. Okay, so malignant hyperthermia. See, from your anesthesia, I want you to understand, see, this malignant hyperthermia is caused by using which agents? Succinylcholine, sevoflurane, halothane. So these drugs, halothane, succinylcholine, sevoflurane, these are the drugs. If you use these drugs, they may precipitate, okay, they may precipitate this malignant hyperthermia. And what is the problem at molecular level? The problem with the malignant hyperthermia is the gain of function mutation of RYR channel is opening for long duration of time. So in this condition, what you have to do? In this condition, malignant hyperthermia, you have to block this RYR channel. You have to close this RYR channels. So what is the RYR channel blocker? That is dantrolene, sodium, dantrolene, sodium. Okay, if a person is having malignant hypothermia, the muscles are contracting for so long time, so muscle fibers will be damaged. Okay, muscle fibers will be damaged. So damage of the muscle fibers is going to leak the myoglobin, and that myoglobin will cause kidney failure. Okay, the patient with the malignant hypothermia is going to have myoglobinuria. Okay, myoglobinuria. Okay, and the patients are also going to have acute renal failure. They may end up in the renal failure because of this myoglobin nephrotoxic thing. Okay, so these are the points which I want you to know for your exam: DHPR channel, RYR channel, Cerca pump. Okay, these are the points which I want you to know. Next, so what exactly is this calcium doing? Okay, what exactly is this calcium doing? I have told you the calcium is responsible for the muscle contraction. The calcium is going to be helpful in the muscle contraction. So what exactly is this calcium doing? For that purpose, you have to understand the regulatory proteins. First, now let me explain you about these regulatory proteins. Okay. Say, look, what are the two regulatory proteins? Troponin. Okay, troponin, it's a regulatory protein. Troponin, it is made up of three subunits: troponin T, troponin C, and troponin I. These are the three subunits. See, troponin C is the one which binds with calcium. Just remember this one point. Troponin C binds with calcium. So what? So what? I will explain you. Troponin C binds with calcium. Just first remember this. Next, the next important regulatory protein is the tropomyosin. Okay, tropomyosin. What is the function of tropomyosin? See, on the, for example, look, see here, this is the sarcomere. Here I am showing you two Z lines. These are the two Z lines. Who is attached with the Z lines? Who is attached with the Z lines? You know, actin filaments. These are the actin filaments, let's say. These are the actin filaments. In the center, which filament is there? Myosin filament. Let's say here, this is the myosin. Now, look at the actin. On the actin, actually, there are active sites present. Okay, on the actin, what are there? There are these active sites. Okay, on the actin, there are active sites present. Okay, like this. Now, these active sites are actually covered. The active sites are actually covered. So, who is this molecule? This yellow color molecule is covering the active sites. So, this yellow color molecule is called as a tropomyosin. So, tropomyosin covers active sites on actin. Tropomyosin covers active sites on actin. Okay, it's covering the active sites on actin. So, who is attached with this tropomyosin? So, tropomyosin, it is attached with troponin C. Okay, troponin C. Okay, troponin is attached. Okay, troponin is attached. So, troponin, it is attached with tropomyosin. Troponin is attached with tropomyosin. Okay, of course, different subunits are there, TNT, TNC, TNI. Simple understanding is troponin C, it is in connection with tropomyosin. Okay, now let me add more to the story. Here, these structures which I am showing you, look carefully here. What are these things? These are myosin heads. Okay, so what are these? These are myosin heads. These myosin heads, they have a capacity, okay, to go and bind with active sites on actin. Always what these myosin heads want to do? They want to go and bind with the active site. They want to go and bind with the active site. and causes the contraction and causes the sliding of the actin filaments so that the sarcomere size shortens. But the problem is, who is sitting in between them? Okay, this boy and girl always they want to meet, but who is sitting in between them? There is this stupid fellow, this bestie guy is there. Okay, in the same way, this tropomyosin is sitting between actin and myosin. Okay, so they are regulating the muscle contraction. So the point which I want you to know is tropomyosin. Tell me, tropomyosin in skeletal muscle, it covers active sites on actin. Okay, it covers active sites on actin. So now what happens during the muscle contraction? You already know the story. When the alpha motor neuron is activated, alpha motor neuron, when it is activated, it will release what? Acetylcholine into the neuromuscular junction. Because of this acetylcholine, I have told you, there will be sodium influx into the cell. Because of the sodium influx, there will be depolarization. Okay, there will be depolarization. Because of this depolarization, which is happening on the muscle membrane, okay, which channels are activated? DHPR channels are activated. The activated DHPR channel opens which channels? RYR channels. This is called as electromechanical coupling. Okay, now once the RYR channels are opened, calcium comes into the cell. Okay, calcium comes into the cell. Now what this calcium will do? Calcium will go and bind with troponin C. Calcium is going and binding with troponin C. Now see, once the troponin C is bind with calcium, troponin C will move the tropomyosin away. Okay, so now this calcium and troponin C, once the calcium binds with the troponin C, this troponin C moves. It moves tropomyosin away from active sites. So what happens because of this? Active sites are exposed. Once the active sites are exposed, immediately what is going to happen? Next, immediately once the active sites are exposed, myosin heads binds with active sites. Okay, so myosin heads, they will go and bind with the active sites. So now cross bridge formation occur. After this cross bridge formation, what exactly happens? There will be contraction of the muscle. Okay, there will be contraction of the muscle because of the sliding filament theory. Okay, so that sliding filament theory also I will explain you here in a 5 minutes. Sliding filament theory, how exactly the muscle is getting contracted because of this actin myosin interaction, how exactly the sarcomere is getting contracted. Now let me explain you sliding filament theory or cross bridge cycling. Okay, cross bridge cycling. Now what exactly happens? See, for the first time, now the active sites on actin, let's say this is the actin filament. Okay, this is the actin filament. So who is exposed on the actin filament? Now it's the active sites are exposed. Now the active sites are exposed. Now what is this filament? This filament is myosin. Now who is there here? On the myosin, these myosin heads are there. Okay, myosin heads, these are all the myosin heads. Okay, now who is attached with the myosin heads? Now look, at this point of time, there is ADP plus inorganic phosphate attached. ADP plus inorganic phosphate attached. Okay, so from where this ADP and inorganic phosphate are coming, I will explain you. But what happens once the active sites are exposed? Okay, once the active sites are exposed, immediately this myosin heads will go and bind with the active sites. They will go and bind with the active sites. This is called as cross bridge formation. Okay, cross bridge formation. Tell me, does this cross bridge formation requires any ATP? No need of ATP. No need of ATP. Okay, now what is the status of the myosin head? The status of the myosin head is 90 degrees. It's 90 degrees. Straight went and it attached. Okay, now what happens? Look, now the second step is, now this inorganic phosphate is released. Okay, after binding, now this inorganic phosphate is released. Okay, this is the first event that's going to occur. Inorganic phosphate is released. Because of the removal of the inorganic phosphate from that area, the myosin head from 90 degree angle is going to bend to 45 degree angle. Okay, so now say, so here is actin, here are the active sites. Now who is attached with the active sites? Already cross bridging happened, cross bridges are formed. Now look, initially these myosin heads, they are at which angle? 90 degrees angle. Now what is happening? Now inorganic phosphate is released. ADP is still attached. ADP is still attached. Only who is released? Inorganic phosphate is released. Because of this release, now the myosin heads are going from 90 degree to, they are going to bend. They are going to bend the heads. They are going to bend to 45 degrees. So because of this, what happens? Now they are pulling the actin filaments. Now they are already bind with the actin filaments. Now when they are bending, they are going to pull the actin filaments. This event is called as power stroke. So power stroke occurs due to release of inorganic phosphate. Okay, in the beginning. So what is the ending then? What is the ending? Okay, so when it comes to 45 degree angle, okay, from the cocked position, 90 degree angle is called as a cocked position. From the cocked position, it is going to come to 45 degree angle. It is going to come to 45 degree angle. Now once it comes to 45 degree angle, ADP is released. ADP released. So I can say something like this: during power stroke, ATP are required? No ATP required. No ATP is required. No need of ATP. What is happening in the beginning? Inorganic phosphate is released, and in the end ADP is released. So power stroke completed. Okay. Now after power stroke, what is the next thing that should happen? There should be detachment. Now the myosin head from that active site, it should detach. It should detach. Okay. So cross bridge breaking. So how this cross bridge breaking occurs? Look, these are the active sites. Now what is the status of myosin heads? Look, now the myosin heads, see, they are all bending. They have already bent 45 degrees. Okay, they are all bent. Now what should happen? They should detach from there. Okay, contraction completed. Now they should detach. Now for detachment, okay, now here there is no one, ADP is released, inorganic phosphate is released, there is no one attached with the myosin head. Now a new ATP molecule is required. A new ATP molecule is required for the detachment. So write cross bridge breakage. Okay, cross bridge detachment requires a new ATP. Okay, now this is the place where ATP will be utilized in the muscle contraction. So now what happens? Because of the attachment of ATP, just attachment. Okay, because of the attachment of the new ATP, now look what is happening. There is cross bridge breakdown. Okay, so let me write here what is happening. So here is the actin filament. These are the active sites. Here is the myosin. Okay, now myosin heads. See, now these myosin heads, they are all detached. Okay, now they are all detached. Why? Because who is attached? ATP, new ATP molecule is attached. Okay, new ATP molecule is attached. See, the problem now is they are in 45 degree angle. Now they are in 45 degree angle. From 45 degree angle, they have to again go back to 90 degree angle, so that they will go and bind with a new active site and causes the contraction. Okay, so now this breakdown of ATP, look, attachment of ATP is leading to detachment. Attachment of ATP, binding of ATP will lead to detachment. So now what should happen is this ATP, okay, let me, detachment completed. Now look, at the next event, now see, here are the myosin filaments, here are the heads. See, now what exactly is happening? Because of the breakdown of this ATP, now myosin head from 45-degree angle, again they are going to their cocked position. Okay, they are going to cocked position, 90-degree angle. So what exactly is happening now? So now here the ATP is broken down into ADP and inorganic phosphate. In the beginning I have asked you from where this ADP is coming, from where this ADP and inorganic phosphate are coming, because of the hydrolysis. Okay, so breakdown is going to make it again 90 degrees. Okay, they are going back to their relaxation position or cocked position, 90 degrees. Okay, so the point which I want you to know for your exam are cross-bridge formation, they don't require any ATP. Power stroke, they don't require any ATP. During power stroke, who is released? Inorganic phosphate is released as well as ADP is released. And next, cross-bridge detachment requires ATP. Okay, binding of ATP is going to cause a detachment. Next, hydrolysis of ATP, breakdown of ATP is going to bring the myosin head from 45-degree angle to cocked position again, so that it will go and bind with the new active site and causes the contraction. Okay, so these are the important points about the sliding filament theory. Okay, sliding filament theory. For example, if the patient is dead, okay, there is a person who is dead. Okay, suddenly he is dead. If he is dead, what happened to the ATP? ATPs are not available. ATPs are not available. If the ATPs are not available, means tell me, do you think these cross bridges will be breaked? No, cross bridges are not going to be breaked. So muscle is still in contraction. The muscle is left in the contraction. That is called as rigor mortis. So if a person is dead, ATP is not available. So no cross bridge breakdown. Okay, no cross bridge breakdown. That's going to cause muscle contractions. The muscles are left in contracted state. That is called as rigor mortis. Okay, that's called as rigor mortis. So these are the important points which I want you to know regarding the muscle contraction, skeletal muscle contraction. Okay. In cardiac muscle, what are the points that are little different? Look here, this is the sarcolemma of the cardiac muscle. Okay, this is the sarcolemma of the cardiac muscle. Let's say this is the sarcolemma. Here is the T tubule. Here I am showing you the L tubule. Look. Here is the L tubule. Same, on the T tubule, which channel is present? DHPR channel is present. It's a DHPR channel of a different subvariety. Okay. Here RYR channel is present, RYR type 2 channel is present. Okay, but subvarieties I am not concerned. RYR channel. Okay. Now see, when the muscle is getting depolarized, okay, when the muscle is depolarized. Previously I have explained you in the skeletal muscle. Previously what I have explained you is this DHPR channel opens RYR channel. That's what I have explained you. But in cardiac muscle, see, in cardiac muscle, what is different? Okay, what is different? Look, when the muscle is getting depolarized, okay, when the muscle is getting depolarized, it allows the calcium influx into the cell. First calcium is coming, okay, through the DHPR channels. So little extracellular calcium came into the cell. So through the DHPR channel, this calcium came. This is little different. Now this calcium stimulates the RYR channel. The calcium stimulates the RYR channel to release the calcium again, because here also calcium is available. So now more and more calcium will be coming from the sarcoendoplasmic reticulum. So this is called as calcium induced calcium release. Okay, calcium induced calcium release. It's the extracellular calcium which is first coming into the cell and stimulating the RYR channels to release more and more calcium from the sarcoendoplasmic reticulum. This is called as calcium induced calcium release, which is seen in myocardium. And this event is also called as electrochemical coupling. Electrochemical coupling. Because in your exam they can ask you, electromechanical coupling is happening in the skeletal muscle. Electrochemical coupling is happening in the myocardium. Why it's called as electrochemical coupling? Because see, there is an electrical event which is leading to release of calcium into the cell. Okay, so electro for depolarization, and chemical here, what is that chemical standing for? Here the chemical is nothing but the calcium. Okay, so the membrane depolarization is going to release the extracellular calcium into the cell, and this extracellular calcium, this calcium is stimulating the RYR channels to release more and more calcium, and you know, once the calcium is available, muscle contraction will occur. So this calcium which came from outside, this is called as essential calcium. Okay, MCQ. So this is called as essential calcium. It came from outside and stimulates the sarcoendoplasmic reticulum to release more and more calcium from the RYR channels. So electromechanical coupling occurs in skeletal muscle, electrochemical coupling occurs in cardiac muscles. Okay, so after this, next what I want you to know is regarding the motor unit. In muscle physiology, I want you to know regarding motor unit. So what exactly is a motor unit? One motor neuron, look, one motor neuron, it's having this axon, and here what is this? Nerve terminal, and these are axon knobs. For example, here how many axon knobs are there? 4 axon knobs are there. This is one motor neuron. Okay, this is one motor neuron. So it is attaching with how many muscle fibers? It is attaching, it's forming a synapse with the 4 muscle fibers. Okay, the whole structure which I have shown you here, it's a motor neuron, one motor neuron along with the muscle fibers. Okay, along with its muscle fibers, this is called as motor unit. Okay, motor unit. For example, there are different sizes of motor unit. For example, let's say this is the other motor neuron, it's the other motor neuron. It is coming like this. It is forming how many axon knobs? For example, look here. Okay, see, now it is forming more number of synapses with more muscle fibers. So here more muscle fibers are getting innervated by this one single motor neuron. So this is also motor unit. Now tell me, which is a bigger motor unit? Sir, this is a bigger motor unit because more number of muscle fibers are involved. 1, 2, 3, 4, 5, 6. It's a bigger motor unit. This is a smaller motor unit. 1, 2, 3, 4 only. So what I want you to know is there are different sized motor units. Okay, there are different size. There are small motor units, small, and there are large motor units and largest. Okay. So what is the importance? What kind of questions that can come up in your exam is, say for example, if I want to do a simple work, okay, first which motor units are recruited? Small motor units are recruited because small motor units are having small number of muscle fibers, so little muscle fibers. Okay, the little muscle fibers in this muscle. In a muscle there are many muscle fibers present. Okay, so if I want to do a simple work, first smaller motor units are recruited. And if I want to do more work, for example, I want to lift a dumbbell, more number of motor units will be recruited, large motor units will be recruited. And if I want to hold, for example, a 50 kilo thing, which is impossible, so my muscles need to contract more, they have to generate more force, so more larger motor units will be recruited according to Henneman's principle. Okay, there is something called as Henneman's size principle. According to Henneman's size principle, first small motor units are recruited. Okay. Next, large motor units are recruited. Next, largest motor units are recruited. This is the order. Okay, order of recruitment. Okay, order of recruitment. In this way, these muscle fibers are recruited. But when the muscle is relaxing, okay, when the muscle is relaxing, de-recruitment will occur. Okay, de-recruitment is going to occur. So de-recruitment occurs in opposite direction. First, largest motor units will be de-recruited, followed by large motor units will be de-recruited, next followed by small motor units are de-recruited last. So the one who is going to get recruited first, is the one who is going to be recruited last. Okay, so the point which I want you to know is simple. There are different size motor units. First of all, what is a motor unit? I have explained you. One motor neuron, it is innervating how many muscle fibers? Okay, that is called as a motor unit. There are small motor units and large motor units. According to Henman's principle, first small motor units are recruited for the purpose. If they are not sufficient, large motor units are recruited so that large fibers will be contracted, more number of fibers will be contracted, so more force can be generated. So in your body, the point which I want you to know is, what are the examples of small motor units? Where the small motor units present? Small motor units present in extraocular muscles, okay, large motor units present in leg muscles like soleus, gastrocnemius, okay, and back muscles. The small motor units are also present in hand muscles, okay. These things which I want you to know regarding the motor unit. Not only this, the force generated in a muscle, is not only dependent on the motor units. Say for example, let's say something like this: force generated is directly proportional to number of motor units recruited. For example, let's say more motor units are recruited, large motor units are recruited. If large motor units are recruited means more muscle fibers are going to get contract, okay, because they are large motor unit means more muscle fibers are involved. So the force generated is also going to be more. Not only this, what else I want you to know is, force generated by a muscle is also directly proportional to force generated is also directly proportional to the frequency of motor unit. The frequency of motor unit stimulation. Okay, the frequency of motor unit stimulation means the more the number of times you stimulate, a motor unit, the force generated by the muscle, the force generated will increase. How? That I will explain you in the 4 graphs, muscle twitch graphs, which may come up in your exam. Okay, there is a chance that they can come up in your exam. So look here, first here on x-axis, I am talking about the time. On y-axis, I am talking about the tension or force. Now imagine I am stimulating a muscle at 0 second. I am stimulating a muscle. I have stimulated a muscle, a motor unit. Let's say I have stimulated a motor unit. When you stimulate a motor unit, what happens? The muscle fibers, they will contract, they will relax. So now a muscle fiber is getting contracted. After that, the muscle fiber will be relaxed. Muscle fiber is contracted and relaxed. The blue color line is contraction and this green color line is relaxation. Okay, contraction, relaxation. So this whole graph, whatever I have shown here, this is called as a muscle twitch. Simple muscle twitch graph. Okay, here I am showing you the contraction and relaxation. Means, see, during contraction, the force generated is increasing. And during relaxation, the force generated is decreasing. Now the point which I want you to know is, see, there is a gap. Here you have stimulated, but muscle contraction is starting at this area. So what is happening during this time? During this time there is no muscle contraction. You have stimulated, but nothing is happening. So this period is called as latent period. Okay, or latency period. Okay, now say during this latency period what exactly is happening? Now for example, imagine, say if I ask you to do some work, okay, do this work. Do you think are you going to do immediately? No, first you will plan how to do it, right? In the same way, when you stimulate a muscle, the muscle membrane should be depolarized, the DHPR channel should open, RYR channel should open, the calcium should come into the cell, the calcium should have to go on by with troponin. So troponin will remove the tropomyosin, a lot of events will happen. Okay, so all these events are happening during latent period. So during latent period, what exactly is happening? If you have to say in one single word, during latent period, the calcium is getting released from the sarcoendoplasmic reticulum. Okay, so during latent period, the calcium is getting released from sarcoendoplasmic reticulum with the help of electromechanical coupling. Due to electromechanical coupling, the calcium is getting released. After that, contraction, relaxation. Done. Simple. Now, look, let me draw the same graph, but let me talk about the frequencies. For example, here x-axis, here y-axis. Now I have stimulated. Now when I give a stimulation, what happens? The muscle will be contracted and the muscle is relaxed. See, muscle is contracted, it's generating some tension. So when the muscle is getting relaxed, I am giving a stimulation. See, here I am giving a stimulation one more time. Okay. Now see, this is the second contraction of the same motor unit. The same motor unit I have stimulated. The same motor unit, the same motor neuron again I have stimulated. So again the muscles are going to contract. But now say these muscles are generating more tension now. Again they are relaxed. Again one more time I am stimulating. So again look here. The force generated in the third contraction is even more. Again I have stimulated it. So the force generated in the fourth contraction is even more. So what exactly is happening? So when you are stimulating it again and again, okay, when you are stimulating the same motor units, the same motor neuron again and again, the force generated by the same motor unit is kept on increasing. This is called as staircase effect. Okay, staircase effect or trippy. Okay, staircase effect are also called as trippy. Now, what is the reason for this? A staircase effect? See, now look, when you stimulate a muscle, you know, contraction, relaxation. For that purpose, what do you require? Calcium. So look here, imagine this is the muscle cell. Okay, here is a muscle cell. Now here is the sarcoendoplasmic reticulum. Okay, this is the sarcoendoplasmic reticulum which is releasing the calcium during muscle contraction. During relaxation time, what happens? The calcium, it will go back. Okay, once the muscle is relaxed, the calcium is going back with the help of circa, you know it. Now what happens is the calcium movement into the circa, so the calcium movement back into the sarcoendoplasmic reticulum, it takes some time for the movement of calcium back into the sarcoendoplasmic reticulum. But what we are doing now, immediately you are stimulating the motor unit. When you stimulate the motor unit immediately again and again, the calcium, the full calcium is not going back. So calcium is staying here. So even before the calcium going back into the sarcoendoplasmic reticulum, again and again you are stimulating the motor unit. So what happens? Calcium is getting released and the calcium is not going back. The whole calcium is not going back. So every time more calcium is getting available. So more calcium means, you know, the calcium is responsible for the muscle contraction. As you have more and more calcium, that causes more powerful contractions, more force will be generated. Okay, so what I want you to understand here I gave you two principles. Force generated is dependent on the size of the motor unit. Okay, the more the size of the motor unit, larger the motor unit, more force will be generated. More the number of motor units recruited, more more force will be generated. Not only that, the frequency, if you give repeated like stimulations, the force generated in the next contraction is going to gradually increase. This is called as staircase effect. Okay, so this is due to, tell me why there is this staircase effect. This is due to availability of more calcium. Okay, this is due to availability of more calcium. This may come up in your exam. The staircase effect at repeat is due to availability of more calcium. So the first muscle twitch, the first muscle contraction and the second muscle contraction. The second muscle contraction is generating more force when compared to the first muscle contraction. The third one is generating more force when compared to the second one. Okay, like this. 4 times it will happen. Okay, 4 times. First stimulation, first, second, third and fourth. So 4 times this force is getting increased, but everything is having a limit. Okay, everything is having a limit. Don't think that your muscles are going to generate more and more force again and again and again and again. It will happen for 4 times. For the 5th stimulation, see here I am giving the 5th stimulation. Let me show it with other color. 5th stimulation. Now from here the force generated is going to be constant. The muscle is contracting, relaxing, but the force generated is going to be constant. It's now the same. From the 4th time it's going to be same. Okay. So this is called as the staircase effect or tripping. Now let me show you one more graph, the same muscle twitch graph. Look here. Now what am I doing? Look, here I am giving the stimulation. When I give the stimulation, what happens? Muscle will contract and it is trying to relax. Muscle is trying to relax. But complete relaxation haven't happened. Now when the muscle is getting relaxed, now I gave one more stimulation. Muscle is not getting relaxed completely. I gave immediate stimulation. Now you tell me what happens. Again muscle will start to contract. But look the second contraction. The second contraction is going to have generating the more force. You know it. Okay, you know it already because more calcium will be available because the muscle is not completely relaxed. More calcium is still present in the cytoplasm. So the second stimulus is going to produce more contraction. Now again here muscle is going to relax. Muscle is relaxing. Okay, not completely relaxed, muscle is getting relaxed. So immediately you give one more stimulation. So see, this is the third muscle twitch, contraction, relaxation. Okay, so look at the force. First one is generating less force, second one is generating more force, and third one is generating even more force. You know the reason. And again this muscle, okay, now it is again getting relaxed. But even before its relaxation, one more time I am stimulating, one more time, for the 4th time I am stimulating. What is happening? Again muscle will contract. Again muscle will contract. Okay, now 4th time, see even it is generating more force. So now look, from now onwards you stimulate again and again. See what happens is the force of contraction is going to be stable. The force of contraction is going to be stable. Okay, muscle, now what's happening? Muscle is contracted, relaxing, again you have contracted, relaxing, again you have contracted, relaxing, again you have contracted. Means for the first 4 times there is increase in the force generation. You know, this is staircase effect. Okay, so this effect, you know, it's a staircase effect. Okay, so whenever you see such a kind of graph in your exam, this is called as incomplete tetanus. Okay, incomplete tetanus. But the point which I want you to know is, see here the muscles are not completely relaxed. They are not completely relaxed. Okay, even before their relaxation they are partially relaxed. Okay, they are incompletely relaxed. Even before the relaxation you are stimulating them again, so they are generating more and more force. Okay, now let me show you one more graph. Look here, x-axis, y-axis. Now what am I doing is, say I am stimulating. Okay, I am stimulating a muscle. When you stimulate a muscle, it is going to generate contraction. Okay, it is going to cause the contraction. Now the contraction is not completed. Then there is no relaxation. It's still in contraction phase. Now it's still in contraction phase. Again, immediately you have stimulated again. Okay, you have stimulated this muscle fiber again. You have stimulated this motor unit again. So when you stimulate it again, now this is second contraction coming. You know the second contraction will generate more force. Again you have stimulated even before the completion of contraction. The contraction is not completed. Again you have stimulated this muscle fiber. Again you have stimulated this motor unit. So it's going to generate one more contraction with more force. More force. The force is increasing. See. Now if you stimulate it again for the 4th time, even it will generate more force. Means for the 4 times, you know, the force is going to be more and more. From the 5th time, see what happens. The force generated is going to be constant. You stimulate it any number of time, the force is not going to increase. So there is continuous line. So when you see such a kind of graph where you are giving repeated stimulation, so that muscle is completely in the contraction phase, there is no relaxation. No relaxation at all, not even incomplete relaxation. It's a sustained contraction. Now the muscle is in sustained contraction. Okay, So the sustained contraction is called as complete tetanus. Okay, the sustained contractions are called as a complete tetanus. Okay, so now 4 graphs. See here, this is the complete tetanus. Here I have shown you the incomplete tetanus where there is a partial relaxation, immediate stimulation. Partial relaxation, immediate stimulation. Now here I have shown you the staircase effect at trepi. For the 4 times, the force of contraction is going to increase. Okay, and from the 5th time, the force of contraction is going to be same. And here this is the normal muscle twitch. Okay, normal muscle twitch. So what is the time duration for the normal muscle twitch? 100 milliseconds. Latency period, the time period for the latency is 10 millisecond. And the contraction, what is the time for the contraction? How much time it is taking? It's a 40 milliseconds. And this period is called as a contraction period. And relaxation, how much time it is taking? This relaxation is called as a relaxation period. It takes 50 milliseconds. The point which I want you to know is one muscle twitch, that is contraction and relaxation, is taking how much time? It takes 100 milliseconds. Okay, it takes 100 milliseconds. So 10 plus 40 plus 50, 10 plus latency period, contractile period and relaxation period. So 10 plus 40 plus 50, so one muscle twitch is going to take 100 milliseconds. Now I have given this info not as a random thing, because in your exam they will ask you questions like, what is the formula for the tetanizing frequency? How to calculate tetanizing frequency? Tetanizing frequency. So tetanizing frequency is 1 divided by contraction period. 1 divided by contraction period. 1 second divided by the contraction period. You know 1 second means how much? 1000 milliseconds divided by what is the contraction period? For example, let's say normal contraction period is 40 milliseconds. So now how much it will become? It is 25 hertz. So what is this? This is the tetanizing frequency of that particular muscle. Means if you give, this is the frequency 25 times, 25 hertz. If you stimulate that muscle or a motor unit 25 times in a second, okay, 25 times in a second, that muscle will be in complete tetanus. It will be in sustained contraction. Okay, if you stimulate that motor unit 25 times again and again, 25 times, there is no relaxation at all. That muscle is completely in the contracted phase, sustained contraction. See, I am keeping this muscle completely in a contracted phase. For that, I have to give 25 impulses, 25 times again and again. You have to stimulate it. So that is the tetanizing frequency, 1 divided by contraction period time. Okay, they will ask you so and so muscle. What is the calculate the? They will tell you what is the muscle twitch duration, contraction duration, relaxation duration, latency period, and they will ask you calculate the tetanizing frequency of this particular muscle 1 by contraction period. Will tell you. Okay, so with this, one and all, we have completed the muscle physiology. We have completed. Let's see from the beginning. We have completed the structure of the sarcolemma, which proteins are there in the sarcolemma. Also, we have discussed the sarcomere important points, Z lines and anatomical zones, histology like I band, A band, like H zone, M line. And also we have discussed about the regulatory proteins, anchoring proteins. We have discussed about what are the changes during the muscle contraction. Okay, Z lines approach together. Okay, A band size doesn't change, H band decreases, I band decreases. We have discussed, and also we have discussed about the sarcotubular system, the RYR channels, the DHPR channels, electromechanical coupling, electrochemical coupling. We have discussed how muscle contraction, skeletal muscle contraction is different from the cardiac muscle contraction. We have discussed about the electromechanical coupling and electrochemical coupling. We have seen that thing, and also we have discussed about the cross bridge cycling. Okay, the cross bridge cycling, that is like when ATP is required. Okay, when power stroke is happening. Okay, cross bridge detachment requires ATP. So this sliding filament theory is also completed. Motor unit important points with whatever you need to know, and these graphs. Okay, muscle twitch graph, staircase effect, trippy, incomplete tetanus, and sustained muscle contraction, tetanus, complete tetanus is completed. Okay, now at the last, I want you to know a few more important points regarding the smooth muscle. Okay, smooth muscle. Okay, the smooth muscle. Same. important points. These smooth muscles are spindle shaped muscles. Okay. See, for the contraction of a skeletal muscle, you require action potentials. For contraction of smooth muscles which are there in your viscera, which are involuntary in nature, the smooth muscles are involuntary. They require action potentials, but not always. Even smooth muscle contract without action potentials. So no need of, not always, there is no need of action potentials or depolarization. Okay, not always required. So which muscle contraction does not require action potential? Smooth muscles. Okay, so between the smooth muscles, what are there? Something important, for example, imagine this is a smooth muscle and here is the other smooth muscle. Here is the other smooth muscle. So in between the smooth muscles, there are gap junctions present. Okay, there are these gap junctions which are present between the smooth muscles. Next, see, smooth muscle contraction is not exactly like the skeletal muscle contraction. No. Here the smooth muscle contraction is regulated by myosin. Okay. It's regulated by myosin light chain. It is regulated by myosin light chain. Okay. In skeletal muscle contraction, we have seen that the contraction is regulated by the tropomyosin. Tropomyosin is going to cover the active sites, so that actin and myosin are not interacting. We have discussed. Okay. Here, say the smooth muscle contraction is regulated by myosin light chain. Okay, it's modified in such a way it will regulate the contraction of the smooth muscles. So what is this? Look here carefully. So you are having, let me write, myosin light chain, and let me write myosin light chain. Okay, normally, first let's say start from here. Myosin light chain is there. It is not in a phosphorylated state. What you need to do is you need to phosphorylate it. This is the MCQ. So only the phosphorylated form of myosin light chain is going to involve in contraction. That's it. Simple. So first, during relaxation time, during resting time, what kind of myosin light chain is there? It's a dephosphorylated. Okay, dephosphorylated form is there. Dephosphorylated form is there. Now you have to phosphorylate it with the help of enzyme called as myosin light chain kinase. Okay, with the help of this enzyme called as myosin light chain kinase, what you are doing? You are causing the phosphorylation of the myosin light chain. So now once it is phosphorylated, now this myosin head is now activated. It will go and bind with the actin and causes the cross-bridge cycling and sliding filament theory. Okay, but the point which I want you to know is it is the myosin light chains are regulating the contraction of the smooth muscles. Which form is required? Only phosphorylated forms. Only the phosphorylated form is going to cause the contraction. Who is going to cause this phosphorylation? Myosin light chain kinase. Okay. Now question is, who is going to activate this myosin light chain kinase? Who activates this myosin light chain kinase? Who activates it? That is calcium calmodulin. Okay, so calcium calmodulin complex. There is something called as a calcium calmodulin complex. Once this is present inside the smooth muscle, okay, once the calcium calmodulin complex is present inside the smooth muscle, that calcium calmodulin complex is going to activate the myosin light chain kinases, and they are going to phosphorylate the myosin light chain. So phosphorylated myosin light chain is going to cause the contraction of the smooth muscle. Now after contraction, what do you require? You should be having the relaxation. Again, it should be dephosphorylated. So for that purpose, there is myosin light chain phosphatase. So this myosin light chain phosphatase is going to cause the dephosphorylation of the myosin light chains, so that what happens? There will be relaxation. Okay, there will be relaxation. Now, in your exam, what they can ask you? So, who increases this calcium in the cell? In the smooth muscle, first the calcium should come, so that the calcium will go and bind with the calmadulin. So, calcium first it should be there. So, that calcium will go and bind with the calmadulin. So, this calcium calmadulin complex is going to activate the myosin light chain kinases, and that will help in the muscle contraction. First, who increases this calcium? Who increases this calcium? The calcium is increased by a secondary messenger called as IP3. In the smooth muscles, inositol triphosphate, which is nothing but a secondary messenger. This inositol triphosphate is going to stimulate the release of calcium. Okay, inositol triphosphate is going to stimulate the release of calcium. Okay. Now, which secondary messenger in your exams, this question can be there, which secondary messenger is releasing the calcium? IP3. Okay. So, calcium binds with calmadulin. So, this calcium calmadulin complex activates myosin light chain kinases. They will do phosphorylation of myosin light chain, so that helps in the contraction. Okay. Next, what else I want you to know is which secondary messengers inhibit this myosin light chain kinase? Who inhibit this myosin light chain kinase? Is, look, let me write here itself. It's the CAMP. Okay. So, cyclic AMP inhibits myosin light chain kinase. So, cyclic AMP is the one which helps in the relaxation of the smooth muscles. Okay, relaxation of the smooth muscles. Next, who activates this myosin light chain phosphatases? Who activates this myosin light chain phosphatases? CGMP. See, here I have written the CAMP. Look here carefully. The CAMP, it's a secondary messenger. CGMP, cyclic GMP, it's a secondary messenger. Okay, it's a secondary messenger. See, these secondary messengers, what they are doing? CAMP and CGMP, one is inhibiting, see, it inhibits the myosin light chain kinase, other is activating myosin light chain phosphatases. Both these two, so I can say something like this: CAMP and CGMP, both are helping in the relaxation. So, these two secondary messengers are helping in the relaxation. But which secondary messenger is helping in the contraction? IP3, inositol triphosphate, is going to help in the contraction of the smooth muscle. And don't forget in the smooth muscle, there is no tighten, no muscle spring, elasticity is not going to be there. Okay, because of the absence of tighten, there is no elastic recoil, there is plasticity. Okay, it is easily stretchable. Plasticity. Okay, plasticity is due to absence of tighten. Is due to absence of tighten. Okay, so the point which I want you to know is tighten is not present in the smooth muscles. Troponin is not present in the smooth muscles. Okay, T-tubules are not present in the smooth muscles. Okay, next, nebulin is not present in the smooth muscles. These are the important points which I want you to know. Okay, next, regarding the smooth muscle, look, here dephosphorylation happened. Here dephosphorylation happened. See, the dephosphorylated myosin light chain. Okay, once it is dephosphorylated, it should detach from the active sites. Okay, phosphorylated myosin light chain attaches with the active sites. Dephosphorylated myosin light chain should immediately detach. Ideally speaking, it should detach. Okay, but in smooth muscles, even this dephosphorylated form is not going to get detachment. It's not going to get detachment immediately. So, still the muscle is present in contracted state. That is called as latch bridge. Okay, latching. This myosin light chain is going and it's latching with the active sites. It's not releasing even after dephosphorylation. So, that bridge is still present. So, this is called as latch bridge phenomenon. So, simple for your exam, a single liner kind of thing, latch bridge phenomena is seen with smooth muscle. Smooth muscle contraction requires myosin light chain kinases. phosphorylation of myosin light chains. Who is going to increase the CAMP levels inside the cell? Calcium. Calcium binds with calmodulin. Calcium calmodulin complex activates myosin light chains. Titin is absent. So no elasticity, there will be plasticity. Okay, there will be plasticity. There is no troponin, no nebulin. Okay, these are the points which I want you to know. So with this, all the important MCQs, what are all required from the muscle physiology. Okay, I know I have taken almost 1.5 hours, but if you know all these things before going to the exam, okay, even if you know this much before going to the exam, you can solve the MCQs from the muscle physiology. Now, in the next video, I will be discussing about the nerve physiology. Now, let's continue with the rapid revision of nerve and neuron. Okay, now let's discuss important points about the neuron and nerve. You can expect one MCQ from this chapter, neuron and nerve. Okay, one MCQ will be coming from the muscle physiology and one MCQ will be coming from the nerve physiology. Okay, in this nerve physiology, first let's start from the basics. Okay, if you look at a nerve, inside a nerve, what do you have? You are having fascicles. Okay, inside the nerve, there are fascicles present. Just like the muscles, inside the muscle, there are many fascicles present. Okay, inside the nerve, there are fascicles. These fascicles, inside the fascicles, you are having neurons. Okay, neurons are present inside the fascicles. Now, coverings. I want you to know the coverings. These nerves, the complete nerve, for example, if you take one nerve, okay, these nerves are covered by epineurium. Okay, epineurium. The fascicles are covered by perineurium. Okay, perineurium. And your neurons, individual neurons, the axons of the individual neurons. There are hundreds and hundreds of neurons present in one nerve, right? One nerve, there are many neurons present, and these individual neurons, they are covered by endoneurium. Okay. Now, important MCQ is this perineurium, this fellow, this perineurium, it acts like, this is the one providing the blood neuron barrier. Okay. So, the cells of the perineurium along with their tight junctions, in between the cells of the perineurium there are tight junctions. So, this layer MCQ acts as a blood neuron barrier. Okay, so that's the important point which I want you to know. After this, let's see the structure of the neuron. Structure of neuron and important points. Now, this neuron, for example, let's say here is the cell body. This is the cell body of the neuron. And what are these things which I am showing here? These are the dendrites. Okay, these are the dendrites which are going to receive the information from the surrounding neurons. They are going to receive the action potential from the surrounding neurons. Okay, now this area is the cell body with the dendrites. Now this cell body, it continues as axon, you know it. This is the axon. Now this axon is going to end here. Okay, now what are these? These are the axon knobs or nerve terminal. This is a nerve terminal with, these are the axon knobs. Okay, there are axon knobs. What is this? This is the axon. Now, most of your neurons, they are having this myelin sheath around them. Okay, the myelin sheath. So, let me draw the myelin sheath here. Okay, now look carefully. First, let's start from the main central thing. That's a cell body. Cell body. So, cell body is also called as soma, perikaryon. You know it already. They are not the MCQs. MCQs. The cell bodies are biggest for which neurons? Which neurons have the big cell bodies? The answer is large cell bodies and small cell bodies. Okay, small cell bodies. Large cell bodies are there for those neurons which are present in the ventral horn of the spinal cord, or you can say the motor neurons in the ventral horn of the spinal cord. The ventral horns. Okay, the motor neurons in the ventral horns of the spinal cord. Okay, they contain the large cell bodies, and small cell bodies are seen for which neurons? It's the granular cells of, okay, granular cells of cerebellum. Okay, these granular cells are also nothing but the neurons. The granular cells are nothing but the neurons which are present in the cerebellum. So they have the smallest cell bodies. Largest cell bodies are there for the motor neurons in the ventral horns of the spinal cord. Now, if you look at the cell body, inside the cell body, there are these things present. There are these structures present. These structures which are there in the cell body, these are called as nissel bodies. Nissel bodies. So what are these nissel bodies? Okay. These nissel bodies are nothing but the endoplasmic reticulum, rough endoplasmic reticulum. Rough endoplasmic reticulum itself means endoplasmic reticulum along with the ribosomes. So nissel bodies are present in the cell body, not in the axons. Only nissel bodies are present in cell bodies. What are these nissel bodies? Nissel bodies are nothing but the rough endoplasmic reticulum with its ribosomes. Now, whenever there is a damage to the neuron, there will be dissolution of this nissel bodies. That process is called as chromatolysis. So dissolution is called as chromatolysis. Okay, this process is called as chromatolysis. Nissel bodies are the aggregates of endoplasmic reticulum and the ribosomes. The dissolution is called as chromatolysis. Next, what else I want you to know is, see, there is a thickened part of the cell body. This is the thickened part of the cell body. It's still cell body, it's not the axon. So this thickened part which I have highlighted here, this is the part of the cell body. This is called as axon hillock. So it's called as the axon hillock. It's a part of the cell body. And what is the first part of the axon? There is this first part of the axon. Look, this is the first part of the axon. So this first part of axon is called as initial segment. Okay, initial segment. Okay, now let's talk some important points about this myelination. See, this myelination, okay, its myelination is done with which cells? Which cells are doing this myelination? The myelination is done by oligodendrocytes in the central nervous system. In the central nervous system, the neurons which are present in the central nervous system, that is the brain and spinal cord. The neurons which are present in the central nervous system, that is brain and spinal cord, they are myelinated with the help of its cells, oligodendrocytes. The myelination in the peripheral nervous system, that is the cranial nerves and the spinal nerves, the myelination is done with the help of Schwann cells. Okay, Schwann cells do the myelination. So oligodendrocytes do the myelination in the central nervous system and Schwann cells do the myelination in the peripheral nervous system. Now exception is the second cranial nerve, optic nerve. Optic nerve, it's a cranial nerve. It's a second cranial nerve. So it should be myelinated with the help of Schwann cells, but that's the exception. So it's the oligodendrocytes. Oligodendrocytes are going to do the myelination of the optic nerve. Remember that point. Okay. Next, what are the gaps between these myelin sheaths? The gaps between these myelin sheaths are called as nodes of Ranvier. Nodes of Ranvier. Okay. So what is the important points about these nodes of Ranvier? Nodes of Ranvier, they consist of maximum number of voltage gated sodium channels. Okay. Voltage gated sodium channels. Okay, they contains a maximum number of voltage gated sodium channels, and these voltage gated sodium channels, okay, the voltage gated sodium channels, okay, maybe sodium channels which are voltage gated. These voltage gated sodium channels, they can be blocked with the help of a drug. What is the drug? That is lidocaine. Okay, so the lidocaine is going to block the voltage gated sodium channels. Lidocaine is xylocaine, which is a local anesthetic. Next, what I want you to know here is, see, this one neuron, it's going to form connection with the other neurons. Okay, this one neuron is going to form the connection with the other neurons with the help of this axon terminals. See, these axon terminals are the ones which are going to go and fuse with the, are going to form the synapse with the dendrites of other neurons. So this is the place where the neurotransmitters will be released. Now, if I am talking about the action potential, if I talk about the action potential, from where the action potential is originated. Okay, if they ask you from which region of the neuron action potential is originated, look carefully. Action potential generation. See, if I am talking about a sensory neuron, in sensory neurons, the action potentials are generated, the electrical impulses are generated from the nodes of Ranvier. Okay, from the nodes of Ranvier. If I am talking about a motor neuron, the action potential is generated from initial segment. Initial segment. Okay, you know initial segment, which is the first part of the axon, initial segment. So action potential generation is different in sensory neurons as well as the motor neurons. After this, let me tell you what are the different types of neurons. Types of neurons. Of course, you know, based on the function, they are sensory neurons and motor neurons. But anatomically, so what are the different types of neurons? First type of neurons are unipolar neurons, where there is one cell body and only one axon will be present. Okay, this is called as a unipolar neuron. Next, there are pseudo unipolar neurons. Okay, where there is one cell body from which one process is coming out, which is going to divide into two processes. Okay, one central process and one peripheral process. So they are called as a pseudo unipolar neurons. And third one is bipolar neuron. Next, multipolar neuron. Okay, multipolar neuron. Examples they will ask you. Unipolar neurons, where are they present? Unipolar neurons are usually absent in the humans, but if you have to pick one best answer, that's the mesencephalic nucleus. Okay, mesencephalic nucleus of trigeminal nerve. Okay, it's the mesencephalic nucleus of the trigeminal nerve. They contains this unipolar neurons. Pseudo unipolar neurons, where are they present? The pseudo unipolar neurons are present in a region called as a dorsal root ganglion. Okay, the sensory neurons in the dorsal root ganglion are examples of pseudo unipolar neurons. Bipolar neurons, for example, there is one cell body and there are two axons coming like this, two axons coming. So bipolar neurons are present in retina. Okay, in your ophthalmology you would have studied there are 10 layers in the retina. There are bipolar cells, which are the second order neurons in the visual pathway. Bipolar cells, first rods and cones, bipolar cells, ganglionic cells, you know it, right? So retina, it contains bipolar cells. Not only retina, olfactory epithelium. Olfactory epithelium. Okay, next, multipolar neurons are present many places in the body. Let's for example, if you want to give if you want to have one example, that is a motor neurons. Motor neurons. Okay, the alpha motor neurons. They are the examples of multipolar neurons. Now after this, what I want you to know is neuronal stem cells. Single liner questions. The neuronal stem cells. Where these neuronal stem cells are present? The neuronal stem cells are present in hippocampus. Like hippocampus, olfactory bulb. Okay, subventricular region. Okay, so subventricular region. So these are the areas where you can find the neuronal stem cells. Now let's see some important pigments. There is a region called as a red nucleus. You know, red nucleus for the rubrospinal tract, extrapyramidal tract, from the red nucleus to the spinal cord. This red nucleus it contains highest amount of iron. There is a region called as substantia nigra. Substantia nigra. See, in the name itself, it's a substance which is black in color. Nigra means black in color. So why this is black in color? Because of the presence of which pigment? Melanin. Okay, so these are the important points which I want you to know. Substantia nigra contains melanin and red nucleus contains iron. Okay, now after this, the important topics. Now we are going to the really important topics. Okay, these are all basics. Okay, these are all basic things. Now, action potential in a neuron. Action potential generation in a neuron. Now, look carefully. For example, a neuron which is resting. Now a neuron is resting. What is the resting membrane potential? Minus 70 millivolts. Okay, it's a neuron. There is a neuron. It is resting. So its resting voltage is minus 70 millivolts. Now, when you stimulate this neuron, for example, you went and you stimulated a neuron. Okay, there are many neurons which are present on your skin surface. Okay, now you have stimulated a neuron. Now, what happens? Say from 70, because of the stimulus, the voltage is going to minus 55 millivolts because of your stimulus. The voltage is going from minus 70 millivolts to minus 55 millivolts. Minus 70 to minus 55 means the membrane is getting little positive. The voltage is getting little positive. Okay, minus 55. So now what happens? At this area, okay, at minus 55 millivolts, immediately the voltage gated sodium channels, on the neuron are going to open, you know it. So that's going to cause immediate rapid depolarization. The membrane voltage is going to go positive. Depolarization, plus 10, plus 20, plus 30. Okay, something like that. The membrane voltage is getting depolarized. Now when the membrane voltage is depolarized, now what happens? So depolarization completed. This red phase is called as the depolarization. After depolarization, now potassium will start to go out of the cell. Okay, potassium will start to go out of the cell. So potassium is going out. So again voltage is coming down because the positive charges are going out of the cell. Because of which the voltage is coming down. It's even coming less than 70. Even it's becoming less than 70 means it's becoming minus 80. So this phase which I have shown here in this violet color, this is called as repolarization. Okay, this red color phase is called as a depolarization. Okay, depolarization and repolarization. So this phase where it is getting even negative, more negative, okay, than the resting membrane potential. So this phase is called as hyperpolarization. Okay, this phase is called as hyperpolarization. Again, the membrane will come back to resting membrane potential. So how many phases are there? Look, first let's say resting membrane potential. There is resting membrane potential. Initially, what you have? Resting membrane potential. Okay. Now, what you have done? For the first time, what you have done? You have stimulated. Okay, you have stimulated because of which the voltage is going from resting membrane potential to threshold potential. So, this is phase 1. So, what is exactly happening in the phase 1? Phase 1, you gave a stimulus because of which the resting membrane potential is moving from minus 70 to minus 55 millivolts. Now, what is the next event? Phase 2. Phase 2. What is phase 2? That's a rapid depolarization because of the sodium influx. There is phase 2. That is depolarization. Next, after depolarization, there is repolarization. That is phase 3. Phase 3, repolarization. Next, when the membrane is getting repolarized again to resting membrane potential, the membrane becomes more negative. From minus 70, it is even becoming minus 80, minus 90, it is going more negative. So that is called as hyperpolarization. Phase 4, hyperpolarization, becoming more negative. Okay, more negative. So this phase is the phase 4. And again, what is the next phase? Resting membrane potential. So resting membrane potential is phase 5. Okay, phase 5 is resting membrane potential. So these are the phases of the action potential of a neuron. Okay, so phase 2 is depolarization. Depolarization is dependent on, tell me, depolarization is due to sodium influx into the cell. And repolarization is due to, tell me, repolarization is due to potassium efflux, potassium going out. Hyperpolarization, potassium efflux continues, more and more potassium is going down, that's why going out, that's why the membrane is getting more hyperpolarized. Okay, these are the phases of the action potential. Now, look, next topic which I want you to know is the refractory periods. Refractory period. Now look, first let me draw the action potential. Okay, if I show you the action potential here, you gave a stimulus. Because of the stimulus, the resting membrane potential is going from minus 70 millivolts to minus 55 millivolts. Minus 70 to minus 55 millivolts. Okay, let me draw minus 70 here. Minus 70, minus 90 here. Okay, now from resting, it is going to threshold. Okay, after that, there is depolarization and there will be repolarization and little bit hyperpolarization also, again coming back to resting membrane potential. Okay, now this period, starting from the depolarization, say from this period, okay, this area, okay, this is the place where the neuron is getting depolarized. And look, this area, okay, which I have marked here. Now repolarization is happening. Okay, now this area is in the hyperpolarization state. Okay, so this period, this initial period, okay, this initial period, during this initial period, what is happening? There is a depolarization and repolarization. Okay, repolarization is happening. Now during this period, if you stimulate this neuron again, how hard you stimulate, whatever, how hard you give the stimulus, new action potential is not going to be generated. No new action potential will be generated. So this period is called as absolute refraction period. Okay, absolute refraction period. Okay, so what is happening during absolute refraction period? There is no new action potential generation. Whatever you do, how much hard stimulus you give, okay, how powerful stimulus you give, no action potential is going to be generated. They ask you why. In one of the exams they have asked why. Because during this period, absolute refractory period, okay, the voltage gated sodium channels, okay, voltage gated sodium channel, especially the inactive gate, okay, inactive gate of voltage gated sodium channels are closed. So these gates are closed, the sodium channels are closed. So whatever you do, the depolarization and the repolarization, depolarization is dependent on sodium. Okay, depolarization is dependent on sodium. So here the sodium channels are closed, the inactivation gate will be closed. Okay, so once the inactivation gates are closed, whatever you do, however you try, no new action potential is going to be produced. Okay, during absolute refractory period. But during this period, okay, during this period, what happens is, again, the channels, okay, the gates are going to come back to their original position. So during this period, okay, what is that? Now here hyperpolarization is happening. The membrane is getting more and more negative. Now during this hyperpolarization time, again the activation gate and inactivation gates are going back to their original position. So during this period, if you can give a little bit more stimulus, not what is a normal stimulus? A normal stimulus have to take the resting membrane potential to threshold potential from minus 70 to minus 55. But now the membrane is little hyperpolarized. Look, now you have to bring from minus 90 to minus 55. If you can take a voltage from minus 90 or minus 80 to threshold potential, now one more new action potential can be generated. So during this period, a new action potential can be generated, but you have to give a little more extra tip. You have to give extra money, okay, or extra stimulus. So this is called as relative, means relative to normal. Okay, this is relative refractory period. relative refractory period. Okay, here also refractory period. Normal stimulus is not going to generate an action potential. Extra stimulus, you have to give extra stimulus. So relative refractory period, you have more stimulus needed to generate action potential or to depolarize. Okay, two refractory periods are completed: absolute refractory period and relative refractory period. Now after this, all or none law. All or none law. Important for your exam. So what exactly is this all or none law? Now I am talking about one single neuron. I am talking about only one neuron right now. Okay. See, this neuron I am stimulating. I have stimulated this neuron. Okay. For example, let's say here is minus 70 millivolts. Here is minus 55 millivolts. Okay. Now this is the resting membrane potential. These black dots are the resting membrane potentials. These red color dots which I am showing here, these are the threshold potential. This is the threshold potential. Now look what is happening. Now I am stimulating this neuron little bit stimulation. When I stimulate it, the resting membrane potential is going from minus 70. Okay, it's going from minus 70, but it is not reaching the threshold. So again it's coming back. Voltage is coming back because there are a lot of leaky potassium channels will be there. Potassium will be always leaking out. So it is little becoming positive, little depolarized. Again it's coming back. Okay, it's not reaching the threshold. Now I gave a little bit more stimulus now. Now it is also not reaching the threshold potential. Little bit more stimulus, little bit more fluctuation. So these fluctuations here I am showing, these fluctuations are called as local potentials or graded potentials. Okay, they are local potentials. They are not responsible for the depolarization because threshold is not attained. Threshold potential is not attained. But see, the point what I want you to know is, don't think that if I give little stimulus, little action potential is generated. If I give more stimulus, more action potential is generated. No, it's not like that. If you are giving a little stimulus, threshold is reached or not? No threshold. Threshold point is not reached. So there was no action potential. No action potential. Okay. If you give very little stimulus, for example, say let's take a hair and keep it here. I can't even feel it. Okay. Let's take a small paper and you keep it here. That will stimulate, but it's going to be very less stimulation. These local potentials are not responsible for the action potential generation. Okay. But if you give enough stimulus, okay, if you give enough stimulus, that's going to take the resting membrane potential towards the threshold potential. Okay, that's going to take the resting membrane potential to the threshold potential. Now, once the threshold potential is attained, you know what happens? There will be depolarization. There will be depolarization. Okay. Now, after the depolarization, what happens? There will be repolarization, repolarization, and there will be hyperpolarization, little bit hyperpolarization, again coming back to resting membrane potential. Okay, so this is normal. Now, first stimulus, look, this is stimulus, good stimulus. Okay, the threshold potential is attained, so there will be repolarization. Now I am giving more stimulus. See, more stimulus. Do you think more amplitude action potential is going to be generated? No. Even if you give more stimulus, once the threshold, see, now I am touching like this, threshold potential is attained, action potential is generated in the neuron. Now, I am giving little bit more stimulus. Even now, maybe more number of action potentials are generated. But the height, the amplitude of the action potential. See, for example, now I am giving, for example, I am showing the green color. Okay, let's just erase this too first. Okay, now I am giving the second stimulus. This second stimulus is also powerful. I am giving much more stimulus. Even now, say, threshold potential is attained. Okay, even now, threshold potential is attained. There will be depolarization and repolarization, hyperpolarization, and resting membrane potential. See, the height of the action potentials. Okay, in the same neuron, the height of the action potential is always going to be same. Okay, don't think that. If I give little stimulus, there will be little depolarization, repolarization, and if I give more stimulus, there will be more depolarization, more repolarization. No, something not something like that. Once you reach the threshold, this point, once you reach the threshold, the action potential is going to be generated, and the height of the action potential, the amplitude of the action potential, this is called as the amplitude. is always constant. Okay, because once the threshold potential is attained, means all the voltage gated sodium channels are going to open. Okay, don't think that if you give for example threshold potential, for example threshold is attained, so 50 voltage gated sodium channels are open. If you give more stimulus, 100 voltage gated sodium channels are open. No, it's not something like that. No. Once the threshold potential is attained, say for example now threshold potential is attained, all the voltage gated sodium channels will be opened. Now threshold potential will be attained. Now also same number of voltage gated sodium channels will be opened. Okay, maybe the number of action potentials, maybe the frequency may change, but not the amplitude. The amplitude of the action potential is not going to change. So that is called as all or none. See, all or none means if the resting membrane potential is reaching to the threshold potential, the action potentials whatever are getting generated, the amplitude is going to be always same. So all are going to be same amplitude. Okay, what is none? What is this none? See, now what am I doing? I am giving little stimulus. This is sub-threshold stimulus. Remember, this is sub-threshold stimulus. It is going from, for example, let me show in the which color? Let me show in the blue color. Let's see. Now I am giving the sub-threshold stimulus. Now it is going from the resting membrane potential and it is again dying off. It is going from here, it is dying off. These are local potentials, these are graded potentials. These are not going towards the threshold. So there won't be any action potential at all. Okay, don't think that there will be little action potential. No, it's not something like that. Okay, if there is an action potential, full-fledged action potential, full height. If there is no action potential, nothing. So this is called as all or none law. Amplitude is always constant, but frequency may change. Frequency may change. Okay, frequency may change. For example, light stimulus, less number of action potentials. More stimulus, more number of action potentials. So frequency may be different, but the amplitude of the action potential in that particular neuron is always going to be same. So this is all or none law which is needed for your exam. Okay. Next, after this, what else I should teach you is the classification of nerve fibers. Okay, after this, what I want you to know is, before going to the classification of nerve fibers, what are the equations used to calculate the resting membrane potential? How to calculate resting membrane potential? Okay, equilibrium potential is calculated. Equilibrium potential of potassium, equilibrium potential of chloride, equilibrium potential of sodium. That's calculated with the help of a Nernst equation. Okay, Nernst equation. So let me write here equilibrium potential of ions are calculated with the help of Nernst equation. Okay, Nernst equation is used to calculate the equilibrium potential of the ions. For example, if I say potassium equilibrium potential, what is the potassium equilibrium potential? Minus 90 millivolts. What is the equilibrium potential of chloride? Minus 70 millivolts. Equilibrium potential of sodium, it is somewhere around plus 63 millivolts. Okay, equilibrium potential of calcium plus 132 millivolts, something like that. Okay, these are the equilibrium potentials. The important equilibrium potential, potassium, chloride, these two are important for your exam. But if they ask you to calculate the resting membrane potential of any cell, for example, resting membrane potential of a neuron. Okay, resting membrane potential is calculated by an equation which is called as Goldman-Hodgkin-Cat equation. Goldman, calculated by Goldman Hodgkin Cat's equation. Okay, Goldman Hodgkin's Cat's equation. So what is the formula, sir? If you ask me, Vm is equal to RT by F, the permeability of potassium into product of permeability potassium into the potassium concentration outside the cell plus permeability of sodium into the concentration of sodium outside the cell plus permeability of chloride into chloride concentration inside the cell. Okay, divided by permeability of potassium into concentration of potassium inside the cell plus permeability of sodium. They will give you these values into concentration of sodium inside the cell plus permeability of chloride into chloride concentration outside the cell. Okay, so this equation is called as the Goldman-Hodgkin-Katz equation. So this is used to, at least I want you to know the name, Goldman-Hodgkin-Katz equation is used to calculate the resting membrane potential of the cell, and this is the formula. Okay, this is the formula. You have to like introduce the values here. What is the permeability of potassium, and like what is the concentration of potassium, concentration of sodium, concentration of chloride inside the cell and outside the cell. If you keep, you will get the resting membrane potential of that particular cell. In your exams, they might ask you the resting membrane potentials of different cells. Resting membrane potential of some important cells. Okay, important cells for your exam. For example, skeletal muscle. Skeletal muscle. So what is the resting membrane potential of the skeletal muscle? Minus 95 millivolts. Okay, resting membrane potential of a cardiac muscle. Okay, cardiac muscle. It is minus 90 millivolts. Okay, important MCQ. Resting membrane potential of a ventricular myocardium, ventricular myocytes, minus 90 millivolts. Resting membrane potential of a neuron. You already know it, minus 70 millivolts. RBC resting membrane potential, minus 8 to minus 12 millivolts. Next, resting membrane potential of your photoreceptors. Okay, whenever there is light, okay, in the light phase, okay, this is something called as a Wall cycle. During whenever there is light, the resting membrane potential will be minus 40 millivolts. Okay, whenever light is not there, that is the darkness. Whenever there is light, the resting membrane potential will be minus 70 millivolts. Okay, so these are some important resting membrane potentials, okay, which you need to know for your exam. What else you have to know is, see, the resting membrane potential of a neuron is how much? Minus 70 millivolts. It's minus 70 millivolts. Now tell me, the resting membrane potential is equal to, it's equal to what? Equilibrium potential. Okay, equilibrium potential of which ion? I have already told you the equilibrium potential of potassium is minus 90. Equilibrium potential of chloride is minus 70. So now tell me, so neuron is having an resting membrane potential of minus 70, which is equal to the equilibrium potential of chloride, because chloride also have minus 70 millivolts. That's the equilibrium potential of chloride. Next, look here, skeletal muscle. Skeletal muscle minus 95 millivolts, and cardiac muscle, this is MCQ, cardiac muscle minus 90 millivolts. So this is equal to the equilibrium potential of which ion? Potassium. Potassium ion. So potassium also have an equilibrium potential of minus 90 millivolts. So with this, some important MCQs completed. Now next, classification of nerve fibers. Classification of nerve fibers. Okay. Now, different scientists have classified the nerve fibers into different types. They have classified the neurons into different types. Okay. First classification is called as Erlanger, Grasser classification. Okay, Erlanger Grasser classification. According to the Erlanger Grasser classification, the nerve fibers are classified into different types like A, B, and C. They are classified into A fiber, B fiber, and C fiber. Okay. Based on what? Based on what? Based on myelination and based on the diameter, based on the diameter of the neurons. Okay, so these classifications, they are based on what? Based on, classification is based on myelination and diameter. Okay, diameter of axons. and conduction velocity. Okay, so based on these parameters, the nerve fibers are classified into different types, that is A, B and C. Okay, A, B and C. Now, let's say A fibers are highly myelinated. Okay, they are highly myelinated and C fibers are unmyelinated. Okay, they are unmyelinated. B fibers, they are having little myelination. Okay, little myelination. A are highly myelinated and C are less myelinated. So when you are going from A to B to C, what happened to the myelination? Myelination decreases. You are going from A to C, myelination decreases. Okay, myelination decreases. And not only that, if you look at the A fibers are actually very big in size, like this. Okay, A fiber, the axons are having more diameter. The axons are having more diameter. And C fiber, if you look at the C fibers, they are having less diameter. Okay, so B fibers are intermediate. So when you are going from A to C, what happened to the diameter? Diameter decreases. So next one, this is one, myelination decreases and diameter also decreases. Okay, and third point, so when you are going from A to C, as there is less diameter, see C fibers are having less diameter. So for the conduction of electrical impulse, for the conduction of these electrical impulses, it will be hard, there will be more resistance. So when C fibers are having least conduction speed, least conduction velocity. So A fibers are having more conduction velocity. So when you are going from A to C, conduction velocity. Okay, conduction velocity decreases. Okay, so these are some important points which I want you to know. A to C, myelination decreases, conduction velocity decreases, diameter decreases. Now this A fibers, okay, let me write here. According to Erlanger-Grassy classification, there are A fibers, B fibers and C fibers. A fibers are further classified into A alpha, A beta, A gamma and A delta. Okay, these are all A fibers. Now tell me, which fibers will be having highest conduction velocity? Highest conduction velocity is there for A alpha fibers. A alpha fibers are having highest conduction velocity, followed by B, followed by gamma, followed by delta, followed by B, followed by C. Okay, the order. Highest conduction velocity, A alpha. Highest diameter, A alpha. Okay, highest myelination, A alpha. Okay, something like that. Now, these A alpha fibers. Who are the A alpha fibers? Which neurons are the A alpha fibers? Okay, it's very simple. Now, I'm talking about the function. A alpha fibers. What is the function of the A alpha fibers? They are having two functions. A alpha fibers, they are motor. Okay, A alpha fibers are doing some motor function. What is the motor function? Alpha motor neurons. You know, alpha motor neurons causes the contraction of the skeletal muscles. So if this skeletal muscle is contracting, if my skeletal muscles are contracting, those neurons which are contracting the skeletal muscles, they are coming under A alpha fiber. They are A alpha fibers because they will conduct the impulses very fastly. They are highly myelinated and they are very big. They are very big. So the neurons which are causing the skeletal muscle contraction are coming under A alpha fibers. Not only these neurons, but also those neurons which are sensory. Look, some sensory neurons are also coming under A alpha fiber. So which sensations are traveling very fastly? Which sensations are traveling very fastly to your brain? Proprioceptive information. Okay, proprioceptive information. So those sensory neurons which are carrying the proprioceptive information, they are coming under A alpha fiber. Okay, now A beta fibers. Now let's talk about the A beta fibers. These A beta fibers, they are carrying which information? So those neurons which are carrying the touch information. Okay, mainly touch, also pressure. Okay, so those neurons which are carrying the touch information, they are coming under A beta. It's A beta fiber. What are A gamma fibers doing? A gamma fibers, they are also motor. They are motor. Means they are causing contraction of something. What it contracts? These gamma are the motor neurons. They are contracting the muscle spindle. Okay, muscle spindle. So muscle spindles, inside your muscles, there are intrafusal fibers called as muscle spindles. These muscle spindles, they even contract. Okay, they contract. So who is causing the contraction of these muscle spindles? A gamma fibers. Okay, A gamma fibers. Next, A delta. What is the function of A delta? Carries pain sensation. Which pain? Fast pain. MCQ. Fast pain, not only fast pain, cold temperature. Okay, cold temperature. So these are the functions of this A alpha, beta, gamma, delta. Now B fibers. Where do you see B fibers? B fibers are preganglionic. Okay, B fibers are preganglionic autonomic fibers. Okay, you know preganglionic, sympathetic, preganglionic fibers. Okay, for example, if you look here, this is the spinal cord. From the spinal cord, who will come out? These are the preganglionic fibers coming out. These preganglionic fibers, they will go into the ganglion, sympathetic chain, and from here, postganglionic fibers will come. Okay, these are the postganglionic fibers. So the preganglionic fibers are little myelinated. See, these preganglionic fibers are little myelinated. Okay, so they are coming under B type of fibers. These postganglionic fibers are not at all myelinated. They are having very less diameter, so they are called as C type of fiber. Okay, so B fibers are preganglionic autonomic fibers and C fibers are postganglionic. Postganglionic autonomic fibers. Not only postganglionic autonomic fibers, these C fibers. Okay, these C fibers are also going to carry slow pain. Or I should say, so those fibers which carries the slow pain are also called as C fibers. Okay, they are also coming under which classification? Erlanger classification, C type. Okay, if a fiber is conducting slow pain, conducting the velocity slowly. Okay, so that's called as a C fiber. So slow pain is carried by C fibers and also warm temperature. Okay, so important MCQs which I want you to know. So which temperature is carried by the C fiber? Warm temperature. Which temperature is carried by the B fiber? Sorry, not B fiber. A delta fiber, it is cold temperature. Fast pain is carried by A delta fiber. Slow pain is carried by C fiber. Okay. Now there is one more classification which is called as numerical classification. Let me write here. This is Erlanger classification ABC. The same neurons, according to the different scientists, Lloyd and Hall, they have classified the neurons into different types. They gave the different names. Same fiber, same function, just name change. So that is called as a numerical classification. Okay, so according to this numerical classification, look, there are 1A fibers, okay, 1B fibers, 1A fiber, 1B fiber, 1A, 1B. Let me write here 1A, 1B, 2 fiber, 3 fiber, and 4 fiber. Okay, so what exactly are they? These are the same things. For example, say I have told you A alpha, it is having sensory functions. Which sensations it is carrying? Proprioceptive sensation. Proprioceptive sensations from where? For example, if it is carrying proprioceptive information from muscle spindles, that fiber is called as 1A fiber, group 1A fiber, group 1A fiber. Okay, if it is carrying a proprioceptive information from Golgi tendon organs, okay, from the Golgi tendon organs, then it is called as group 1B fiber. Okay, so based on from where it is bringing the proprioceptive information. See, don't confuse, this is a sensory. Right now I am talking about the sensory. Students might be thinking, sir, here also I have written the muscle spindle. This is motor. Okay, muscle spindles have both motor innervation as well as sensory innervation. So sensory innervation to the muscle spindle, is given by group 1A fiber. Sensory innervation to the Golgi tendon organs is given by group 1B fiber. So group 1A fiber and group 1B fiber, they carry the proprioceptive information to the central nervous system. Okay, group 1A and 1B are nothing but A alpha according to Erlanger-Grassy classification. Okay, group 2, okay, 2 is nothing but A beta according to Erlanger-Grassy classification. So group 3 is nothing but B fibers. These C fibers are nothing but 4 fibers. Group 4 is nothing but C. Okay, so it's the same neurons, they are classified differently, they were given different names. Okay, so in your exam, what they will ask you is proprioceptive information from the muscle spindle is carried by 1A. Proprioceptive information from the Golgi tendon organs is taken by 1B. Or you can say A alpha according to Erlanger-Grassy classification. Okay. Now, some more important MCQs which I want you to know for your exam are, if there is hypoxia, okay, if there is hypoxia, which fibers will be damaged first? See, hypoxia is something bad, so we don't welcome hypoxia. So B fibers will be damaged, followed by A, followed by C. So B, A, C. So B fibers will be damaged because of hypoxia. If there is pressure, if you apply pressure, because of the compression, which fibers will be damaged first? Which fibers are more susceptible for the pressure? It is A fibers. Even A alpha fibers will be damaged first, followed by B, followed by C. Okay. Next, with anesthesia. Okay, local anesthetics. If you apply the local anesthetics, which fibers are going to be inhibited first? Okay, anesthetics are going to block the voltage gated sodium channels, and they are going to be inhibited. There is going to be inhibition of these neurons. Action potential generations are inhibited. So if you use local anesthetics, which fibers will be inhibited? It is A gamma. Okay, A gamma followed by A delta, followed by other A fibers, A beta, A alpha. Okay, followed by B, followed by C. So simple, A, B, C, A, B, C. But hypoxia is B, A, C. Okay, so there is a controversy in this area. Local anesthetics, which fibers are inhibited? Some books mention C fibers are inhibited first, but better option is always A gamma. A gamma fibers are first inhibited with the help of local anesthesia. Okay, and one more important point, if you are A gamma fibers, okay, if these fibers, A gamma fibers, whenever they are damaged, that's going to cause damage to this A gamma fibers are going to cause paresthesias. Paresthesia. Okay, paresthesia means tingling and numbing sensations are because of the damage to the A gamma fiber. And even these questions has been asked when you have your hand under your head. Okay, just keep your hand under your head and sleep. Now that's going to cause the pressure, that's going to compress the nerves. So which fibers are going to be damaged? A alpha fibers, because of the pressure. Okay, when you keep your hand under your head and when you sleep, that pressure is going to cause damage to A alpha fibers. A fibers will be damaged. A fibers. So in the morning, you will be having paralysis, weakness. Okay, you will be having weakness for the muscle contraction. Okay, because A alpha motor neurons are damaged. Okay, so with this important MCQs regarding the nerve fiber classification, and also we have discussed a resting membrane potentials of important cells, Goldman-Hatzkin-Scat equation, and all or none principle, refractory periods. We have also seen the action potential, phases of the action potential. Also we have seen some important points. Okay, some important points about the neurons. Okay, so with this, the important points what are needed for your exam, okay, are completed. If you know this much, that will be more than enough. Hope the video is helpful. See you in our next video. Thank you.